Hey guys, welcome back to our channel. If you are new here, do know that we post exciting new content and concepts every week. So do subscribe to our channel, the link of which is given down below in the description. Today, we shall discuss a very important topic of IgG4 related disease. Now, IgG4 related disease is a very important topic for clinicians, for pathologists, for radiologists, and researchers alike. So, without further delay, let's study the radiological manifestations of IgG4 related disease. IgG4 related disease is characterized by a clinico-pathological triad of elevated serum IgG4, that is above 135 mg per deciliter, clinical features that show diffuse involvement of one or the more than one organs, and histopathological analysis that shows lymphoproliferative cells which stain positive for IgG4 staining, and they show storiform fibrosis. So this is the triad of IgG4. Now this is considered both an autoimmune as well as allergic disorder and affects usually more in the age group of 40 to 70 with a median age group of 60 years. It has a slight male preponderance with male to female ratio of 3:1. Now IgG4 related disease affects the entire body, starts from the head ends till the toe. So let us see the head to toe manifestations of IgG4 related disease. This is a beautiful diagram that is given in one of the RSNA articles. So we shall be discussing the head to toe manifestations of IgG4 related disease. In the central nervous system, it causes hypertrophic pachymeningitis and hypophysitis. In the orbit, it causes orbital pseudotumor. Coming to the salivary glands, it causes Mikulicz disease and Kuttner tumor. Then coming next to the thyroid gland below, it causes Riedel's thyroiditis and Hashimoto thyroiditis like picture. Then in the lung, there is of course lymphadenopathy, then interstitial lung disease and pulmonary pseudotumor. Next, coming to the abdomen. This is the most common manifestation of IgG4 related disease and it presents with autoimmune pancreatitis. The next most common is sclerosing cholangitis. Other manifestations in the abdomen are lymphadenopathy, autoimmune sclerosing mesenteritis, retroperitoneal fibrosis. It can also present as liver pseudotumor, and in the renal system, it presents as tubulointerstitial nephritis. However, there are more presentations. We shall go in depth when we study the renal system. It can cause inflammatory aortic aneurysm, and coming to the gonads, it causes prostatitis, testicular involvement. And finally, the musculoskeletal system involvement is characterized by presence of pseudotumor or pseudolymphoma, also known as cutaneous pseudolymphoma. Now, the way we shall discuss IgG4 related diseases, we'll start with the most prevalent disease manifestation, that is abdominal manifestations, then go on to less prevalent manifestations of this disease. So in abdominal manifestation, the most common manifestation is autoimmune pancreatitis, IgG4 related autoimmune pancreatitis. There are three variants: type 1 lymphoplasmacytic sclerosing pancreatitis, type 2 idiopathic duct-centric chronic pancreatitis, and type 3 drug-related autoimmune pancreatitis, that is mostly the tyrosine kinase inhibitors. Now more about these types and the IgG4 levels in each type is already discussed in our chronic pancreatitis and miscellaneous pancreas related videos that is released the previous week. You can go ahead and watch that. Now in this video we shall be mainly concentrating on the imaging of this IgG4 related autoimmune pancreatitis. In imaging appearance, there are two variants, that is focal as well as diffuse. In focal, the head of the pancreas is the most common affected organ or part of the organ, whereas in diffuse, there is uniform infiltration of the pancreas. On CT, in the focal variant, there is a hypodense mass involving the head, whereas in the diffuse variant, there is a hypodense infiltration that involves the entire pancreas with loss of lobulations of the pancreas. This has been classically described as sausage pancreas. Associated with the sausage pancreas, there is a hypodense rim that surrounds the pancreas, which shows progressive enhancement. This is known as the hypodense rim sign. Okay, coming to the MRI appearance. On MRI, the imaging is T1 hypointense, T2 hyperintense, and it shows delayed enhancement on dynamic scan. Similar in the diffuse variant, whereas the T2 hypointense rim, it shows progressive delayed enhancement, meaning in the arterial phase there will be mild enhancement of the T2 hypointense rim around the pancreas. In venous it increases, and in delayed it almost mirrors that of the pancreas. So let us see some images to fortify our knowledge. This is the CECT. You can see here by the arrow mark that there is a hypodense mass that is hypoenhancing relative to the pancreas, that is replacing the head of the pancreas. Now if you see closely, this arrowhead represents main pancreatic duct that is showing periductal enhancement. So this is a case of focal IgG4 autoimmune pancreatitis. Coming to the diffuse variant, this is very classical. There is a hypodense infiltration of the entire pancreas that shows loss of lobulations. This is the classic sausage pancreas. This is known as the sausage pancreas. Along with it, you can see this hypodense rim that is surrounding the entire pancreas. Now, if a delayed scan was performed, this would enhance. Let's see the same patient MRI. We can see that the entire pancreas is infiltrated and it shows loss of lobulations. So this is the sausage pancreas. We can see the T2 hypointense rim surrounding the pancreas. Now this is the early arterial phase and this is the delayed phase. You can see here that this T2 hypointense rim shows hypoenhancement as depicted here by these arrows, and on the delayed films it almost mirrors that of the pancreas, the enhancement character. So this was a classical case of diffuse IgG4 related autoimmune pancreatitis. Now what you have to remember is that there are two stages of IgG4 related autoimmune pancreatitis. First is the active stage. Here we get the classic sausage pancreas, the hypodense halo sign, and in this stage the FDG PET is positive. This is where most of the patients are diagnosed as having autoimmune pancreatitis. Next stage is the chronic stage. This usually happens after treatment, treatment being immunomodulators or steroids. After treatment, the hypodense halo disappears, the pancreas becomes almost atrophic, and it shows FDG PET negative. Now, when I was teaching this to my residents, they asked me a very important question that, sir, this focal autoimmune pancreatitis, it looks almost like PDAC, meaning pancreatic ductal adenocarcinoma. How do we differentiate it? So there are two important signs that help us to differentiate this focal autoimmune pancreatitis from pancreatic ductal adenocarcinoma. The first sign is on the T2, you can see here that there is infiltration of hypodense mass involving the head of the pancreas. On MRCP, you can clearly see that the duct, main pancreatic duct, is not abruptly cut off. In fact, it is penetrating into the mass as well as it is showing narrowed caliber. So there is no abrupt cutoff. In fact, it is penetrating the mass. So this is known as duct penetrating sign. Coming to the next sign, you can see here on the CECT that I have put it with an arrow mark that just distal to the head, meaning the neck region. If it was PDAC, it would have been abrupt cutoff. But here you can see that it is tapering, meaning narrowing towards the head mass. So this is known as ice pick sign. The tapering portion in the neck region is known as ice pick sign. So these are the two signs that differentiate IgG4 related autoimmune pancreatitis, especially the focal one, from pancreatic ductal adenocarcinoma. Alright, IgG4 related autoimmune pancreatitis is the most common manifestation of IgG4 related disease. It presents in 90% of the cases. Now, the next most common is IgG4 related sclerosing cholangitis. This presents in around 70% of the cases. Now, what you need to know is this sclerosing cholangitis, 90% of these patients also have autoimmune pancreatitis. However, the 10% present with only isolated IgG4 related sclerosing cholangitis. Now, in sclerosing cholangitis, both the intrahepatic as well as the extrahepatic ducts are affected, with the most common portion of the CBD that is affected is intrapancreatic CBD. This is very evident, as you can logically think that autoimmune pancreatitis is present in 90% of these patients, and the portion of the CBD that is in continuation with the pancreas is the intrapancreatic CBD, meaning the distal most CBD. Coming to the imaging appearance. In imaging, there is periductal homogeneous enhancement of a rind of soft tissue that is present around the bile ducts, especially the CBD. And there are, in the end stage, it presents with strictures and proximal dilatation. The gallbladder can also be affected. Most commonly, it presents with symmetric wall thickening. However, asymmetric wall thickening that masquerades as carcinoma gallbladder is also documented. So you need to take this with a pinch of salt that you see autoimmune pancreatitis, whereas you in the same scan you see that gallbladder shows asymmetric wall thickening. Take it with a pinch of salt. Do not directly label it as carcinoma gallbladder. It can very well be manifestation of IgG4 related sclerosing cholangitis. Let us see some images. In this CECT, you can see that the CBD is infiltrated by a soft tissue that shows enhancement. There is periductal soft tissue that is enhancing. This one that I have highlighted in red is the periductal soft tissue that shows enhancement. Associated with it, there are strictures with proximal bilobar intrahepatic biliary duct dilatations. Another example we can see on MRI, this is the T2 weighted image, we can see bilobar intrahepatic biliary radical dilatation, and on the corresponding T2 image lower down section, we can see that this is the CBD that I have highlighted here with arrow, and there is T2 hypointense soft tissue rind that is surrounding the CBD. We can also see that there is sausage pancreas. So, as I said, if the patient has sclerosing cholangitis, there is a 90% chance that he also has autoimmune pancreatitis, as in this case. In the same case, ERCP and MRCP was performed. In ERCP, we can see that there are multiple strictures associated with dilatation. The same can be confirmed on MRCP. Now, a very close differential here is sclerosing cholangitis, that is primary sclerosing cholangitis. There, the strictures are usually small, less than 3 mm in length, and they produce a prune tree appearance, whereas here the strictures are usually long and they do not produce that prune tree classic appearance that you see in primary sclerosing cholangitis. If you see autoimmune pancreatitis along with this, you are almost confirmed that it is IgG4 related sclerosing cholangitis. Now, having done with the two most common manifestation of IgG4 related disease, we shall move ahead with salivary and lacrimal gland involvement. As I had told in that head to toe image that it presents with either Mikulicz disease or with Kuttner tumor. What is Mikulicz disease? Mikulicz disease is characterized by painless swelling or involvement of two or more than two of these glands, that is lacrimal gland, submandibular, parotid, sublingual. Any two of these or more than two, if they are involved, then this is Mikulicz disease. Then on CT, it presents with enlarged glands which show homogeneous attenuation and enhancement. The enhancement is usually delayed, they are not arterially brilliant enhancing, whereas on venous and delayed, they show good enhancement. Now, what you need to know is if a person presents with painless enlargement of the lacrimal gland associated with the parotid, the submandibular, sublingual, there are two important differential diagnoses. First one is Sjogren's syndrome, that is in the active stage. The second being lymphoma. These two must be ruled out before you label him as IgG4 related disease. Coming next to the Kuttner tumor, this presents as a hard swelling involving either one or both of the submandibular gland. Let us see some images. You can see here in this image, this is a T2 weighted image. There is enlargement of bilateral parotid. There is enlargement of bilateral submandibular. There is enlargement with homogeneous contrast enhancement of bilateral lacrimal gland. So this was a classic case of Mikulicz disease. Next, a similar patient, it showed enlargement of bilateral parotid glands, bilateral submandibular, bilateral sublingual glands. So again, a classic case of Mikulicz disease. You can see that these glands show homogeneous enhancement, and even on T2, they are homogeneously T2 hyperintense. Coming next. Next is IgG4 related orbital involvement. It presents as orbital pseudotumor. This pseudotumor is basically a soft tissue mass that shows homogeneous enhancement. It can involve the lacrimal gland, it can involve the extraocular muscles, and it classically spreads along the tract of the optic nerve. Let us see an example. You can see here that there is a T2 hyperintense mass involving the left lacrimal gland, which shows homogeneous appearance. Now, this is another example, a uniformly enhancing soft tissue mass that is involving along the tract of the optic nerve, involving the intraconal segment that is here in the anterior portion, as well as spreading into the intracanalicular portion of the optic nerve. So this was also a case of IgG4 related orbit involvement, that is pseudotumor. Next, moving down to the next gland that presents as IgG4 related thyroiditis. This presents as two manifestations, that is Riedel's thyroiditis and Hashimoto thyroiditis. In Riedel's thyroiditis, you are already aware that it is rock hard on palpation with extensive fibrosis. Whereas Hashimoto thyroiditis, it is a type of lymphocytic thyroiditis, and in this particular scenario, when these plasma cells or lymphocytes are stained, they stain positive for IgG4 and they show the classic storiform appearance on histopathology. Coming next to CT, this can either be focal or more commonly the diffuse variant. It shows low attenuation relative to the normal thyroid gland and does not enhance as much as the normal thyroid gland. The normal thyroid gland on non-contrast CT is usually hyperattenuating because of the high iodine content. Whereas in this IgG4 related disease, it is replaced by hypoattenuating mass. You can see here, this is the diffuse variant. This is a non-contrast CT where the entire thyroid is replaced by this hypoattenuating mass-like infiltration that usually attenuates much less than the normal thyroid gland. Coming next to the IgG4 related renal disease. Now in renal disease, there are 5 patterns of involvement. You should know that there are more than one pattern, and if anyone asks, you may enumerate all 5 of them. The first and the most common one is bilateral round peripheral cortical lesions. This is the most common pattern. Next, there is diffuse patchy involvement. Third, there is a rim of soft tissue that surrounds the renal parenchyma. Fourth, there can be bilateral nodules in the renal sinus. And last, there can be thickening of the renal pelvis. Let us see some examples. Here in this CT, you can see the first, that is bilateral renal cortical nodules involving both the kidneys that are hypoenhancing as compared to the normal renal parenchyma. This is the most common variant of IgG4 related renal parenchymal involvement. Coming next, there is a rind of soft tissue that is surrounding the renal parenchyma bilaterally. This almost resembles the hairy kidney sign seen in Erdheim-Chester disease. So Erdheim-Chester disease is a very close differential diagnosis to IgG4 related renal parenchymal involvement. Now coming next, this is the T2 fat sat where you can see hypointense nodules involving both the renal parenchyma. Here on diffusion, you can see that these show true diffusion restriction. The EDC value I have not given here. However, these show true diffusion restriction. Now, what I want you to remember here is these renal lesions, they show diffusion restriction. During my MD final exam, I was given 3 cases and 1 hour time for interpreting all the 3 main cases. Now, the first 2 cases, I found them a bit difficult and I ended up spending 50 minutes on the first 2 cases. So I was left with only 10 minutes for the last case. And when I opened the last case, they had given me an MRI brain, a CT of the chest, an X-ray of the chest, a triphasic CT of the abdomen, an MRCP of the abdomen, and finally a musculoskeletal involvement, that is knee joint. So then I thought to myself, in 10 minutes, it is not possible to accurately interpret all of these. So what did I do? I did a simple thing. I went ahead and I thought that since they are giving all the systems, it means it is a multi-system disorder. Either it is an autoimmune disease or it is cancer. So since they have given two scans of the abdomen, let me first check out abdomen. So first, when I put the portal venous phase CT of this triphasic CT patient, I saw that he had sausage pancreas with hypodense rim. I was almost confirmed. Okay, he has an autoimmune disorder. Next, I saw that I next put an MRCP film and immediately I saw strictures. Now I knew that this is IgG4 related disease. He presented with the two most common manifestations, that is autoimmune pancreatitis and sclerosing cholangitis. Now all I had to do is pick up head to toe manifestations, which all he has. But I was left with only 5 minutes as of now. So what I started with the head. I put post contrast T1 films. I saw that he had hypophysit. Okay, hypophysitis. Next, I went to the chest. I put the mediastinal window. I saw he had mediastinal lymphadenopathy. Okay, picked up. Next, I saw the lung window. He had interstitial lung disease. Okay, next. We already picked up pancreas. We already picked up liver. So only renal was left. And I had 1 minute left. I had to write this down also. So all I did was put a diffusion film. I saw that there are diffusion restricting lesions. So I mentioned here tubulointerstitial nephritis. Now the examiner had also knew the answer, that he had given me an IgG4 related disease case. But he did not know that in the diffusion there were actually diffusion restricting lesions. And when I showed this to him, he was very much impressed. So a point to note is, when you are short of time, always see important sequences. This important sequences you gain experience by doing reporting daily. In this case, it was diffusion. So coming back to the topic, IgG4 related disease related abdominal findings, again it can present as sclerosing mesenteritis and retroperitoneal fibrosis. These are two separate topics and we shall be seeing only examples of these. Here in the CT, you can see that there is a soft tissue within the mesentery. It is causing intense desmoplastic reaction. So this was a case of IgG4 related sclerosing mesenteritis. Coming next, in this CT, you can see that there is a hypodense lesion that is surrounding the aorta and the retroperitoneum. In the same patient, you can see that it is showing hypoenhancement and it is surrounding the aorta. Also, you can see here that this is the ureter. There is medial deviation of both the ureters with associated hydronephrosis of the left kidney. This is a classic case of IgG4 related retroperitoneal fibrosis. This, if you had done an IVU, it would present as maiden waist deformity. Coming to the next manifestation, that is IgG related hypophysitis. This causes inflammation of the hypophysis, meaning the pituitary stalk. It presents as enlargement of the pituitary stalk with post contrast enhancement. You can see here in this T1 post contrast image that the hypophysis is enlarged and shows brilliant enhancement. It is quite uniform. In the next example as well, you can see that the hypophysis is enlarged, it shows enhancement, and the enhancement is spread to involve the pituitary gland as well. So this was a case of IgG4 related hypophysitis with extension into the sella and involvement of the pituitary gland. Coming to the next case. This is a case of IgG4 related soft tissue tumor, or also known as pseudotumor, also known as pseudolymphoma. Now, this was an interesting case. The patient actually went first to the surgery OPD, and my surgery colleague, who was just fresh from his MS, he was very excited. He found a soft tissue mass on palpation. He saw the X-ray. He was very confident it was a soft tissue lesion, soft tissue tumor, and he was very excited to do the OT. He had sent me this referral saying that you do the ultrasound, you do the MRI, and you tell me the extensions. We will straight ahead go for OT the next day. Instead of doing incision biopsy, we'll directly go for excision biopsy, and we can directly see the histopathology on excision. So I was very much okay with it, and we did an MRI and ultrasound. On MRI, we can see that there is a T1 hypointense small lesion involving the gastrocnemius and soleus intramuscular compartment, and on T2 it showed T2 hyperintensity, and on post contrast it showed nice enhancement. Also, the neurovascular structures were separately seen along the anterior and posterior margin. So the lesion was independent of the neurovascular structure. This is a surgeon's dream. He can immediately go to the OT, get it done within 1 hour, and the surgery will be done. Also, I was very interested in this case and I ended up doing an ultrasound. While doing an ultrasound, I see that there was an intramuscular lesion. It showed calcification, as you can see here. So it was very much a soft tissue tumor. There was no doubt, and tomorrow OT was planned. While I was talking to him, he said that he also was an alcoholic and was taking medications. So I was like, okay, he's also an alcoholic. Next, he also said that whenever he takes these medications, his alcohol he used to get bouts of hematemesis, and whenever he takes this medication the hematemesis would resolve, and this soft tissue swelling that he had in his leg, that would also resolve. So I was like, how can a medicine resolve a soft tissue tumor? If it was malignant it would resolve on chemo. However, he's taking only a single tablet. How is it resolving? So I told him to show the tablet. It was actually steroid. Then I asked him, does he have pancreatitis? He said, yes, he does have pancreatitis. And when it aggravates, he presents with hematemesis, especially on bouts of spurge drinking when he used to do. And another thing, whenever he used to take this tablet, the swelling used to come down. I told him to bring his abdominal CT scan. We saw the CT scan. We saw that there was autoimmune pancreatitis. There was sausage pancreas with hypodense rim. So I informed this to my surgery colleague and we had to cancel the OT of that day. This is because it was IgG4 related soft tissue pseudotumor. We again started the patient on a higher dose steroid, and the disease was controlled on this. And after 3 months, the patient again presented to us. He said that his autoimmune pancreatitis has reduced. We did the CT again. Again, the autoimmune pancreatitis had markedly reduced. His musculoskeletal ultrasound was again done by me, and there was no mass. It had completely resolved. So you have to keep in mind that you have to look at the whole body instead of one part and diagnose it as soft tissue tumor. You should be careful. You should see his other comorbidities, whether you can relate this particular lesion with his other comorbidities or other diseases that he has, as IgG4 related disease affects the entire body from head to toe. So this is all for today, guys. If you do like our simplified version of teaching, subscribe to our channel, like and share our videos. If you want any particular topic to be taken, please do comment below and we shall see it as fast as possible. Thank you. Hey guys, if you like our simplified approach to difficult conceptual topics, please do comment, like, share, and subscribe to our channel.